Dean, thank you for joining us.
You bet.
Okay. We're going to go ahead and convene this special called work session of the City Council. Today is April 28th, 2020. We're doing this meeting virtually. The time is 9:02. Colleagues, the purpose of today's called work session is to discuss what the governor has done yesterday in terms of his new orders to increase the amount of economic and social interaction that happens in the city. I wanted to get in front of you three people to speak to the science or the health aspects of issues related to what the governor has done. Now that the governor has issued new orders, we're going to be working, I'll be working together with the county judge about the subsequent orders that we do. There are a lot of legal issues associated with those. We're going to do this meeting until 11:30 or earlier, depending on how this meeting goes, and then go into executive session, and then to end by noon. I think we lose at least one council member a few minutes before noon, so we'll work as quickly as we can. We're going to start this morning with Dr. Myers, who has been the person that has done the modeling for us, University of Texas. She's also been doing pandemic and epidemic modeling for a long time and advises the CDC as well as the White House and others on modeling, and frankly has been really the go-to person for us in this region to tell us what to anticipate, and her work has informed a lot of what we're doing. So she's going to be the first person that speaks. Before we take any questions from her, we're then going to go to Dean Johnston, who will also speak to how we are actually tracking the information and data that comes in. And he'll talk about his thoughts on Dr. Myers' work and how that would be applied to where we are. And then after the two of them have had a chance to speak, and before we take any questions, we're going to let Dr. Escott talk to us as our public health director on what lessons or information or important aspects of the first two presentations he thinks are important for us to make sure that we note. We're then going to take the time after that before 10:30. We'll divide it up and give everybody an equal time, and you can ask a question, make a comment directed toward the three people that have spoken or otherwise. It's your time. That's the process we're going to follow. Dr. Myers put together literally in a few hours, thank you for that, a presentation for us. It's at a really high level. It's illustrations. It is not the detailed analysis and modeling that we would ask Dr. Myers to do, to actually give us real triggers, exact triggers, but it's for the purpose of helping us understand the concepts involved. And in the posting that I posted yesterday, it was this work that I was referring to. She's going to present it visually and then be able to answer questions about it. That has been emailed, I hope, to each of you by the clerk. It's been posted to the message board so that it's available there. If it hasn't been emailed out to you, we had asked for that to happen, but it's posted so on the message board, so it's available to you. And the IT people here, Dr. Myers and Dean Johnston, will pull up onto the screen so you don't have to worry about sharing your screen in order to be able to keep those things up. When you're talking, Dean Johnston has a one-page chart that tracks the numbers, also posted to the message board, also something that will be emailed to the colleagues, and that the IT people will pull it up. And then I think Dr. Escott has his own charts. I don't know if you'll pull those up, but anything that you have, Dr. Escott will post later, and you can pull up. Before I turn it over to Dr. Myers, I'd just say, to my colleagues, generally speaking, I've talked to other mayors now around the state, and everyone's trying to figure out how to react. I think the overwhelming impression from most of the mayors is that they wish that the governor had waited another 2 or 3 weeks to do this so that we would be in a better place with testing, a better place with tracking, a better place with PP, so that we would have that base better established. The governor has acted. No one knows what is going to be the result on the virus spiking or peak of what's happened. We know that it's going to increase. It has to by definition because interactions are increasing. But we don't know whether that's going to put us in a position for a New York-like spike or not. Modelers don't model behavior. They just model numbers. So once we see what's happening, we'll be able to see those data points, and then the scientists and the doctors will be able to tell us, based on those data points, yes, you're headed to a spike, or no, you're not headed to a spike. Our community has done just an absolutely incredible job. When we were looking at this at the beginning of March, we had no idea if a community could actually here in Austin or in the United States could actually make the decision to at over 90% decrease in infections. No one knew the answer to that question. In fact, when we modeled it and saw that that's where we needed to be, we were doing initial planning, assuming that maybe we could get to 75% and trying to figure out what that meant. And there were a lot of people that were saying that 90% was simply something that could not be achieved. The community just did an incredible job and worked really hard, and it's been incredibly disruptive, and there are a lot of people hurting real badly as part of that effort to get above 90%. But what we've learned is that we can do that. What we've learned is that if we go above 90%, we know how long it takes to get back to a flat curve. We know we have that ability. And that's probably one of the most important things that we have learned as a community. Unfortunately, we don't know if we get there because people are staying in their homes, or because people are wearing masks, or people are disciplined at 6 feet distancing. We don't know, which makes it hard to then set up the behavioral protocol that keeps us where we need to be going forward. But we do have the peace of mind in knowing that as we track the numbers, if we start heading for a New York-like spike, we have it within our power to be able to mitigate that and flatten that. I'm concerned personally that the work, the governor has done this a little bit early. I am concerned that he may have gone too far, but the numbers will show us whether or not that's true. I am really concerned when the governor suggests that we'll know in a couple of weeks how the new policies work, because we won't. If there's one thing I've learned, it's that this is a trailing indicator, and it's going to be probably 4 weeks before you actually know. What we're seeing today in terms of new cases is the result of the policies that we had in place 2 weeks ago. And we need, in 2 weeks, when the governor and all of us look at what we're seeing happening, it's going to be a result of what we're doing today, not what we're doing over the next 2 weeks. So that timing issue, I am real concerned about. And then the last thing is, and we can talk about this as a group, regardless of what the governor says, we have the ability as a community to establish our own norms, things that we want done in our community. And a lot of what we've done so far hasn't been because the sheriff has been arresting people or the police have been putting people in jail. It's because we have a community that's wanted to join together in order to help protect one another. We're still in that place. So there are a lot of behaviors that I think culturally and in our city we're going to expect of one another. And I think we should consider establishing still those guidances and those norms in our city, and then recognizing businesses or places that are living to our community standards, and then recognizing, maybe creating in Austin a big sign that somebody could put in their front of their business or in front of their establishment to say, not only are we doing what the governor required, but we're doing what the local community wants done, so that anyone walking down the street or a consumer can know who it is that's helping us and who it is that, even if their conduct is legal, might be something that we believe to be reckless. And then the last thing I would touch on real fast, I think is a real important takeaway, I'll ask Dr. Myers to speak, is the importance of cocooning susceptible and vulnerable populations. The real dangers for us in terms of loss in lives is an inability to be able to cocoon and really protect people in nursing homes, to cocoon and protect people that are experiencing homelessness in our community. But it goes beyond that. It's protecting everybody that's over 65, especially if they have an associated illness or a disease. But it's also figuring out how to protect everybody in our community that has diabetes, regardless of their age, pulmonary, cardiovascular diseases. How do we protect those people? The unfortunate rub we have already seen this is that some of the people that through a history of not having health access, a history of not having healthy foods, are more susceptible today are the people that sometimes are least able on their own to protect themselves because they're most dependent on a job that they have to show up for that they can't delegate. And as a community and as a council, we're going to have to address that because that's the weakness in any kind of response system. That said, I hope I don't talk very much the whole rest of this program. Dr. Myers, can you please talk to us about the modeling?
Yes, I'm happy to. Good morning, everyone. Thank you for everything you do to keep our city safe and healthy and protect all of our livelihoods. We really appreciate it. And I'm really happy to be here and look forward to questions. I'm happy to try to explain anything that's unclear. Can I assume that everybody has this document in front of them, or should I share my screen? What would be the best way to visualize what I'm about to say?
I think that the IT people can pull up anything you tell them to pull up.
Okay. So
is that easier? They have your document.
They have my document. Okay. So I'm just gonna walk you through the figures basically and explain them to you very slowly. So as you may or may not know, we've been building models to project the spread of this pandemic very extensively in Austin, but also around the world. And since really early January, when we first heard about the new virus in Wuhan, that is a different graph. That is Clay's graph.
That's Dr. Johnson's graph. So it's the multi-page document and it's page 5.
Yeah, it's the top graph on page 5. And I'm also happy to share my screen if that would be easier. Let me know. So one thing we've been doing over the last couple months is looking on a daily basis at hospitalization data from the 5-county, that's it, perfect, from the 5-county MSA, and using that hospitalization data, the first hospitalization was around March 13th, to first of all estimate how quickly was the virus spreading in Austin before we closed schools, then how quickly was it spreading in Austin between the day we closed schools and the day of the stay home, work safe measure on March 24th. And then since that order, how quickly is it spreading? And what our analysis confirmed very early on and has reconfirmed every day we look at the data is that under the stay home, work safe measure, we have radically reduced transmission. Our estimate is that compared to the baseline of how it would have spread if we had continued to go about our life as normal as we were in early March, we've probably reduced transmission by over 90%. And that is why we are not seeing gigantic surges in hospitalizations or catastrophic numbers of deaths in the way other cities have unfortunately seen this thing transpire. So this set of graphs are they're pretty complicated. They're not our typical, if you've looked at any of our reports over the last few weeks, they're not simple projections. They are, it's a combination of both projecting what might happen if we relax social distancing and we increase the risk of transmission in Austin, and coming up with an optimal strategy under the following scenario. We imagine perhaps because of the governor's order, perhaps because of changing policy locally, perhaps just because of public weariness, we don't do as good a job at preventing transmission. And what's going to prevent transmission? Well, actual social distancing, people taking precautions when they do come in contact with each other to minimize the risk of the spread, face coverings, keeping their distance, just not going out if you even have the mildest of symptoms, as well as efforts to really ramp up our capacity to not just test and contact trace, but then to isolate, right? What happens when you find a potential cluster of cases? How do you ensure that those individuals are not potentially exposing other people and spreading to other people? And as a side note, I just want to mention, when we look to countries like Singapore or to cities like Hong Kong, and we say, wow, look how successful they have been at going back to life as normal, yet still suppressing transmission. One of the key things that they are doing in those, at least in those two examples, is as soon as somebody tests positive, they are put in a hospital. They are fully isolated, so there's no chance of transmission. So we're talking about, to really get to the point where we're really mitigating transmission, we're talking about a lot of different pieces in place. So today we don't have those pieces in place. Looks like we're on the verge of really relaxing social distancing. So what we're projecting is what might happen under different scenarios where our behavior, our policies lead us to be a little bit more lax and allow the disease to spread a little bit more widely. And then based on those scenarios, we're assuming, well, the only thing we know we have for sure in our toolkit of like how we could contain this is we could go back down to the more strict stay home, work safe order, right? We could, if things get too lax, we could say, you know what, this is looking like it's going to threaten our hospital capacity, and we're going to institute a stay home, work safe order, hopefully for not too long, but we want to at least do it for the minimum amount of time we need to ensure that we don't exceed our local hospital capacity. So that is what these graphs are going to illustrate, different scenarios of what would happen depending on how much we relax social distancing and what sort of an optimized strategy for kind of targeted heavy social distancing would result in. Okay, so the first graph at the very top, these first two graphs are sort of extreme scenarios where there's no optimized strategy. The top one is we're either going to maintain our very strict social distancing, we're going to maintain the strictest stay home, work safe measure all the way through September 2021. We're going to kind of live under the thumb, in other words. If we do that, and now I'm going to orient you to this graph. If we do that, we're going to see a few things. We project a few things. So first of all, the red line is the line that goes through that big red area is our expected number of hospitalizations each day in Austin. Okay, so how many, what is sometimes referred to as heads in beds. How many people are actually today hospitalized for COVID-19 in any one of our MSA area hospitals? And so what we would expect to happen is if we maintain social distancing, so we're going to relax a little bit. We're going to go from the 95% social distancing we have now to a sort of 90% social distancing, but which is still enough to ensure we don't have a huge wave of transmission. We would expect to see hospitalizations and cases climb a little bit more, but peak we've already peaked. So I'm sorry, we were already, that peak is happening right now, right? That's sort of mid-April. We would expect that we've already peaked, that maintaining this heavy social distancing will successfully repress transmission from here on out. So the current peak we have in hospitalizations is the worst we'll see. It subsides. those red error bars, those red fuzzy areas are just showing you our uncertainty, right? We don't know for exactly what's going to happen tomorrow or next week, but given what we understand about the virus, we think it's going to be somewhere in that red area. So worst case scenario, we may see a peak number of hospitalizations of somewhere around 250, and that would happen right away. And that is probably unlikely because we're almost at that peak and we're only seeing roughly 70 to 80 hospitalizations today. So so that's what would happen. It would subside. And at the end of the day, at the end of 2000 or in September of 2021, if we maintain strict social distancing, we would have probably capped total deaths from COVID-19 under 200 with an expected value of 80. So,
hang on a second, Dr. Myers, is there a way, IT, that you can zoom in on that page?
So it's the top graph I'm talking about right now.
Yeah, I'm not sure that we can, but I will give it a shot.
Dr. Myers, can you zoom in on if we go to your shared screen? You want to do that?
I can try, yeah.
We're sharing from here.
Also, I can actually, each of you can manually zoom in, it looks like. I'm zooming in on what IT is showing me. So if you look, there's like a left bar and there's a little, magnifying with a plus. Are you able to do that and then zoom in on the top graph? Does that help?
That works, thank you.
Okay, great. Okay, so we're still looking at the top graph. So the red line and the black line is the deaths. But so if you look at the little band along the bottom of the graph, right, that's time going from now until September 2021. Wherever you see that pinkish purple, that is a time period where our schools have to be closed, right? So this is a very, this is an economically a very costly policy potentially. We're talking about 550 days, over a year of a lockdown, probably entailing schools remaining closed, and that's what we're seeing. The yellow is when schools are actually open. So schools are actually open in that scenario prior to March 14th. So that's assuming that it takes a total lockdown in order to achieve 90% reduction in transmission. We may find ourselves surprised that people are actually able to take precautions and we're actually able to ramp up testing, tracing, isolation, so that we can actually maintain this much of a reduction while still returning to economic life a bit. But that's a pretty heavy lift to get to that point. So assuming now, let's take the other extreme. Assuming now we don't do a very good job, and this is going to take us to the second graph, okay? We're going to assume now that during relaxation, starting basically May 1st or whenever people begin to relax, that our daily activities, our behaviors, our lack of precautions, our lack of testing, whatever it is, the combination of what we can and can't do leads us to a situation where transmission is reduced slightly relative to baseline. If we were fully just like going about normal life, it's going to be reduced by 40% from baseline, but that's a lot less effective than, assuming in the prior graph that it was 90%. Okay. So now we're in a world where we're taking some precautions, but it's only succeeding in reducing transmission by about 40%. So maybe people are wearing face masks. Maybe we're not doing the South by Southwest and the mass gatherings, and there is something, but we're not doing enough to really suppress transmission completely. So you could also, another way to think about this is, for every 2 people you would have infected, maybe you're infecting only 1 person. It's about, it's approximately half as much infection or something like that. So that's this scenario. So now we're going to assume that is the world we're entering now, and we're not going to do anything about it. We are just going to let the pandemic run its course, this second wave. And, the second wave that you're going to see here in red, it is so large that you don't even see our first wave. That little blip over there to the left, around April, that's what we're experiencing right now. And you can't even see it because of what will happen, because of what would happen or what will happen in the coming months if we just let this thing transmit under semi-normal conditions. So what we would project is that those hospitalizations in red would fairly quickly surpass our hospital surge capacity. So that's that red line there, that's horizontal. Across it, it says hospital capacity. Area hospitals have estimated that collectively in the MSA, they can surge to approximately about 3,200, 3,300 beds for COVID-19 patients. So that's how much excess capacity beyond other people who are already in the hospital. One thing to note is this does not incorporate possibly reduced capacity during flu season when we were going to need beds for people who are also being infected with flu. But assuming a flat surge capacity, we project that if we go back to kind of a situation where transmission is only 40% reduced relative to baseline, we will exceed hospital capacity somewhere kind of in mid-summer, and we will remain above capacity, catastrophically, from what looks like the end of June through sort of mid-September, or maybe, September-ish, October-ish, and then it would subside. And then that would be it. It would be a catastrophic second wave. And then we would essentially, you may have heard of this, what we say, reach herd immunity. By the time we get to the end of the second wave, most people or enough people will have been infected, and assuming this disease is immunizing, that our population would not sustain a third wave of transmission. But in this scenario, there are only, that you can see that 38 days of lockdown, that we didn't go into another stay home, work safe period. Those 38 days were just the 38 days we've already experienced up through May 1st. And this kind of surge is exactly what we want to prevent. I mean, those are, the horrible pictures and stories you've been hearing from Italy and New York, et cetera. That's many people dying, many people in hospitals not getting the care they need for months. And at the end, we project that there would be 2,900 cumulative deaths. Now, I want to mention something I haven't mentioned about both these first two graphs. One of the things I'm assuming optimistically in both of these graphs is that although we are going back to life as normal a little bit, at least in the second graph, we are doing a very good job of what we call cocooning our high-risk population. So even though some of us are going back to work and some of us are going to shopping centers, et cetera, people over 65, everybody over 65 and everybody under 65 with a known high-risk comorbidity, particularly things like chronic lung disease, are maintaining sheltering. They are still personally sheltering in a way that reduces their own individual risk of transmission by 95%. So we're assuming that, like, this is sort of a best case, worst case scenario. People go back to life, and we see a ton of transmission, but even though that transmission is happening, we are managing to sequester, to shelter, to cocoon our high-risk populations. So, and we'll see in a minute how much those deaths actually increase if we are not successful at cocooning our high-risk populations. So those are the kind of extreme cases where we either lock down indefinitely or we relax indefinitely. And now I'm going to move on to the second and final set of figures. So if you bring up the next page in the document, please. So the figures I'm about to show you are based on an analysis that was done by my team at UT in collaboration with a team at Northwestern University, who it's actually a professor there who used to be at UT and I worked with for many years in building pandemic preparedness tools for the state of Texas. He's since left Texas for Chicago, and he's really an expert in what we call stochastic optimization. So, imagine that you have a million possible ways we could start lockdowns and end lockdowns, right? Or a million possible different ways we could trigger that. We could be monitoring hospitalization data, and we could trigger it when hospitalizations exceed 50 per day or 60 per day. And so what they've done is they've done an analysis where they've said, let's find the very best possible strategy for initiating lockdowns and relaxing lockdowns. And how do we define best strategy? Well, these are the two objectives we have in doing this analysis. The first is that we absolutely do not want hospitalizations to ever exceed capacity. So that is a firm constraint. We never want to see, we never want to be in that situation that, New York and Italy found themselves, right? So that is a non-negotiable. That is the reason we're going to lock down if we lock down, because we want to ensure we don't exceed capacity. And then the second thing we want to do is we want to minimize the amount of days or weeks that we are under this very strict social distancing orders that I'm calling a lockdown here, right? It's the stay home, work safe kind of order. And lockdown is sort of a pejorative term for it, but that is essentially what it is. Wherever you see lockdown, it's basically we're going back into stay home, work safe. We are going back to a policy we know can suppress transmission by in this case, we're going to say 90%. Okay, so one thing we're not optimizing for here is we are not saying we're trying to minimize lives lost. We are not saying we're trying to minimize the total number of hospitalizations. The reason I'm not showing you that here is because basically if you do that, if you say our goal is to minimize deaths and minimize hospitalizations, the answer will be that very first graph I showed you. Just stay fully locked down or as much locked down as you possibly can for the longest period of time, okay? So this is the way my colleague likes to talk about it, is it's how to gamble if you must. If we are in a situation where because of people's behavior, because of policies that are coming from higher authorities, et cetera, are leading us to a situation where this thing is going to spread more than we want it to spread. And the only tool we have in our toolkit is that we're allowed to for very short periods of time reenact the social distancing order, but we can't do it for a prolonged amount of time because others will tell us we can't, or just the public will stop adhering. They'll grow weary of it, right? So if the only tool we have is really let's go back to a lockdown period. Here's the kind of solution we used our models to figure out. We said, what can we monitor to know whether we're getting into a situation where hospitalizations might soon exceed capacity? Well, we can monitor hospitalizations. Fortunately in Austin, where we have an amazing collaboration between city leaders and the hospital system and the academic researchers, we're able to see on a daily basis, how many people are in hospitals, comprehensively in the MSA. And so what this does is we're going to be monitoring two different things. We're going to be monitoring how many people were just admitted today into the hospital and how many people total are we caring for in the hospital for COVID-19. And what we've done is we have optimized what we call a trigger. There is going to be a value. It's approximately 100 hospitalizations, new hospitalizations in a day. When we get to the point where, maybe there was 10 new hospitalizations one day, and then there was 15, and then there was 20, and we see the number of new hospitalizations climbing. When we get to that day, when we say, oh my gosh, today there were 100 new hospitalizations, we are going to say, we've gotten to the point where we know that if we don't do something, we are very soon going to see an overwhelming surge in hospitalizations that we can't handle, and we need to initiate another stay home, work safe order, okay? And we're going to keep monitoring, and then we're going to do that, and we're going to keep monitoring it, and the hospitalizations are going to continue to increase. It's going to take us a while for that order to take its effect, but eventually the hospitalizations will subside, and when we get back down below that threshold, we'll say, okay, we've achieved what we wanted, which is we've curbed transmission to the point that the outbreak is receding, and we've managed to avert a catastrophic surge in hospitalizations. And when we get back down below that exact same threshold in number of new cases per day, we're going to relax the social distancing order, okay? And the value of that, which is, in these particular graphs I'm going to show you, is around 100, but you got to take that with a grain of salt. It's going to depend on what the amount of social distancing is actually happening in our population. That is guaranteed, if we use the optimal value, that is guaranteed to prevent an unmanageable surge in hospitalizations while also minimizing the number of days that we have to be under the stay home, work safe order, okay? So I'm going to show you two solutions, okay? So in the first one, the first graph, this is sort of the best solution under the scenario that when we relax social distancing starting May 1st, we're going to go into a state where Austin is only reducing transmission by 40% as opposed to 90%. And what we're going to see as we look at this graph is, so that's going to happen on May 1st, is that we're not going to see it right away because when outbreaks spread, because of the exponential nature of epidemic spread, it starts very slow and then it starts to grow exponentially. So we may be lulled into a false sense of, wow, this is working. All through May, we don't see much happening. However, it is setting the seeds for what's going to be exponential growth that's probably really going to come on our radar in maybe early mid-June. In early mid-June, those new hospitalizations are going to, at some point, it looks like it's, where you see the beginning of that lockdown period, that is the day where our new hospital admissions cross that 100 threshold, and we said we have to lock down. So we lock down, because that is what prevents what we saw in the last graph. That is what prevents that line from going way up beyond our hospital capacity. We lock down, And that successfully reduced our or slowed transmission so that hospitalizations naturally sort of curbed, sort of started tailing off. They peaked around, it looks like 2,500 in July, August, and then they start to subside. And then you can see that in September, sort of late September, the new hospitalizations, incident hospitalizations, passed back below that threshold, and we felt comfortable when we relaxed this stay home, work safe order. And people went back to their life where they were only reducing transmission by 40%. And so where you see dark gray, that means 90% reduction. Where you see light gray, that whole area, that's just we're going back to kind of the more relaxed life. And then what happens after that is that because we're going back to relaxed life, we actually see that once again, transmission picks up, we see hospitalizations pick up, but we don't actually have to initiate another lockdown to curb that third wave, because by that time, enough people have been immunized by prior infection in the city that third wave is self-limiting. It's going to burn out on its own because we reach sort of so-called herd immunity in the population. So one thing to notice in this graph is that, one thing to notice is that we end up in this best case scenario, optimal solution, we actually end up with about the same number of deaths that we end up if we had just let it blow through and exceed our hospital capacity. So we don't actually save more lives by doing this. We actually just prevent an excess, we prevent a catastrophic surge in hospitalizations. What you'll notice also along the bottom, where you see the yellow and the purple, so what this particular best scenario entails is, we closed schools on March 14th. We would have liked to have opened schools in August 18th, which is the norm, which is the scheduled opening of the AISD school year, but we're still under lockdown at that point in time, so we can't safely open schools yet. So we postponed school openings by about a month, but we're able to open schools, in late September, and then just the rest of it is just kind of the normal school schedule. We have schools until end of May 2021. We have summer break, and then we go back to school in the fall of 2021. So the last graph I want to show you is it's the exact same setup, but in this case, instead of assuming that we have been 95% successful in protecting our high-risk population. So the graph we just talked about, I'm assuming the whole time that when we are going into relaxed mode, we are still very strictly cocooning our high-risk populations. We are reducing their risk of infection by 95% through this entire period, through the end of 2021, or through mid-2021. In this case, we're going in this last graph, we're going to do the same kind of optimization, but under the more pessimistic scenario that we really just can't protect our high-risk populations, our vulnerable populations that well. We're still going to assume we're achieving 80% effective cocooning. So their risk of infection is basically half the rest of our risk of infection, right? We're reducing our risk of infection by 40%. The high-risk groups, or if you're in the high-risk group, you're reducing your risk of infection by 80%. So we're doing about twice as well at protecting them as we are protecting the lower risk part of our population. And when we optimize, when we come up with the best strategy for triggering, we have to trigger much earlier in this scenario, and we have to trigger much more often, triggering the lockdown, because by not protecting the vulnerable populations, we're going to see probably twice as many hospitalizations and more than twice as many deaths, as you can see over there on the far right. So what that means is that in order to avert catastrophic surges in healthcare, we are going to having to initiate lockdowns in this case, it looks like in this particular solution, after May 1st, it looks like they're preventing a catastrophic surge in hospitalizations is going to entail another sheltering order from beginning to June through almost end of October. That's this first wide lockdown period. And then we get to relax for a few weeks, and then we go back into another, looks like almost 3-month lockdown, and we relax for a while, then 2 more months, we relax for a while, and then 1 more month, and then it's finally out of our system. But that's essentially a continuous lockdown. It's almost a year of sheltering in place, basically. So that's, and you can see schools can hardly be open during that period. Those are the graphs, and that's the scenario. I want to emphasize something that the mayor mentioned earlier. these are meant really to be illustrations of plausible scenarios. They are not forecasts by any means. We really don't know what level of social distancing, what level of transmission reduction we are going to be able to achieve in the months ahead. If we continue to sort of project into the future and think about like our options for intervention in this framework, then what we would want to do is to, on a daily basis, be looking at all of the available data, not just hospitalization data, but if we really ramp up testing, we have better testing information, even looking at cell phone geolocation data so we can indirectly estimate how much people are social distancing. Whatever data we can get, we would want to kind of on a real-time basis be estimating how much transmission is happening and come up with an adaptive strategy. If we look like, maybe it doesn't have to be just a hammer, right? This is a hammer. It's like the only thing we can do is lock down. Maybe in the months ahead, as we learn more about people's behavior, its consequences, we can take a more nuanced approach. But that will require much more data and much more time to plan. And in a prior analysis that we posted and we shared with city leaders, I think just last week, or maybe it was the week before, we looked at a simple question of what happens if we wait to relax. Rather than relaxing on May 1st, we can relax on June 1st, or we can relax on July 1st to start relaxing social distancing in a way that might increase transmission. What we find is that waiting doesn't really change the shapes of these curves or the number of people that are going to die, right? You're just going to postpone that. However, what waiting does is buys us precious time to ramp up testing capacity, to ensure that we have measures in place to cocoon our vulnerable populations, including protecting residents of long-term care facilities like nursing homes, and messaging people, encouraging employers to provide either accommodations so their employees who have high-risk conditions can work from home, or are provided with paid leave if they just can't. There's so many things we can do to protect vulnerable populations, but we can't do all those things by May 1st. So, I think, and I don't know if I think I just said this, but really ramping up testing, tracing, and thinking about, if people keep talking about the success and the importance of testing and tracing, but if you can't then enforce or resource isolation of people if they are exposed or infectious, it doesn't do us as much good, right? And so like all those things just take time, they take resources, and that's what kind of a slow relaxation gives us. It buys us time to do some of this planning. So with that, I'll hand off the mic.
Steve, you're muted.
Really, those were my best words of the whole day. Dr. Myers, thank you very much for walking through that. If you could stay with us, we're going to have Dean talk and then Dr. Escott talk. We're going to lose some of these experts about 10:30, so we're going to try to keep pushing with the experts as best we can here. Dean, you want to give us your thoughts that you think the council should hear?
Sure. Thank you, Mayor, and thank you all for having us today, and thank you for the great work that you're doing. This has obviously been a challenge for all of us, one that we didn't necessarily sign up for, but I'm glad we're all working together on it. First, I want to acknowledge where we've gotten. So, Mayor, you mentioned this a bit, but I think at the very beginning. We had no idea what could happen to us. We were looking at New York and thinking that was our future. And we did have a number of cases early. And we were fortunate to bring testing and make it available here early on. And that allowed us to identify within the community that there were already cases in the community. And that geared us up to make a lot of good decisions about how to begin social distancing and reduce risk. But it hasn't been easy. And I'll tell you on the hospital and public health side, it's been a struggle. A struggle to get adequate testing, a struggle to get coordination across our systems, although that has come around incredibly well, I would say. And also coordination with Austin Public Health. And then the same issues that every other city is dealing with have been major issues for us, the access to PPE, and is it going to be enough, and do we have enough personnel, and now hospital personnel are getting sick, and then how are we going to deal with that? So this has been quite a roller coaster, and that is then with a relatively small number of hospitalized cases, as Lauren showed you on her chart. So I think the remarkable thing is how quickly we shut this down. I think it just shows how engaged our public is and listening carefully to what they should and should not do, and taking their own initiative to behave in ways that have dramatically reduced transmission here. And so our numbers don't look like other cities. They certainly don't look like New York, but they also don't look like Houston. Again, testing and some of the other public health things we've done have helped, but it's really the behavior of the public in response to the policies that you all and the county have put forth, as well as the state, to get things under control. If you could show my slide, which was the one that you had shown initially. We're starting Lauren's. So it's great to know that the behaviors that we saw over the past few weeks can remarkably slow transmission, block transmission, and reduce hospitalizations. As we were watching the hospitalizations grow and grow, we were concerned that we wouldn't be able to turn it around, but we really have. And hopefully that slide will show up.
Is IT here to put on Dr. Johnson's slide? It was the single chart, single graph. Is IT with us?
We're trying to get it up now.
Okay.
Okay. Well, I can keep going while that's coming up. In order for us to have a response that worked, we needed to have all the hospital systems working together, and again working closely with us in public health, and that has been done masterfully. We have now a meeting 3 times a week that includes some of the leaders from UT Del Med, the leaders from Ascension Seton, Baylor Scott and White, St. David's, as well as Austin Public Health, the county judge, and the mayor. And so that group has stayed nicely coordinated. One of our realizations was that we couldn't really track new cases and understand our control of the disease. And the problem was we knew we didn't have perfect testing penetration. We probably have, we're way off in terms of getting everyone tested who's symptomatic. And that was also evolving, changing over time. So although we might get some sense of control based on new cases, that wasn't going to be as reliable as following the numbers who were hospitalized. And that made even more important the data that we got back from the hospital. So we've been aggregating that data and then have had the ability to line that up with projections that come from Lauren's models. So this is gives you the data as of yesterday, and I'll just quickly talk you through it. The top line is cumulative cases, and again, it's going to keep going up. It's cumulative, but you can see that this is on logarithmic scale. It's going up at a less rapid rate, so that's nice. This is for the whole metropolitan area. That suggests that we are slowing the what would be viral exponential growth over time. But the real key curve that we follow is this gray line, and this is the number of hospitalizations, number of people COVID positive in our hospitals in the 5-county MSA on any given day. And you can see that number has stayed relatively flat actually for the past couple weeks, and has started to trend down just a touch. And it was up a bit yesterday, probably just within noise. And then below that is the number of people on ventilators, and that's come down. And then again, for some other places, people on ventilators, the vast majority of them will die. That hasn't been our experience this far, but it's certainly they are the ones at greatest risk for dying. So the nice thing about this is you can see we're now tracking really nicely along this line here, and we're at like 80 hospitalizations at this point. Lauren's graphs were showing, they were not logarithmic, and they were showing that we cap out somewhere around 3,200. That's quite a big leap from here to here on an exponential scale. So we're well below that, that peak. And also we're well below what the optimization models said should be our threshold for slowing down, which were closer on those models to about somewhere close to 1,000 hospitalizations. I just want to put that into context so you all understand what the impact is of 1,000 hospitalizations. First, let's start with the 80 that we have today, then the 1,000, and then an overwhelming system, just so you all have a sense, make that real, because it is real for us, right? It's real for the doctors and nurses and all those people that are working in those places and in caring for these people. So the number of cases we have has dramatically impacted care in the city. So first of all, people are avoiding hospitals. So the hospital volumes are way down. The hospitals are struggling. They're less than half full in general now, close to half full, right around there. And that's creating economic challenges and pressures to furlough, lay off folks. And for some of the other practices that have not even just elective procedures, but things that can be delayed, they're struggling financially quite a bit. Even so, when hospitals do have these cases, it's totally throwing them into stress and difficulties. They're consuming PPE at a much more rapid rate than they normally would, and they're at risk of running out. And we've heard these stories over and over again. And they're having to reorganize the way they deliver care in these places, even for the care of the 80 cases that we have today. And we're getting better and better at it, so people are more comfortable. We're starting to aggregate these patients in wards so they can be cared for together. We're creating negative pressure rooms so that makes their care safer. We're training more docs and nurses to be comfortable. We're getting adequate PPE for frontline workers. So all of that has improved over time, but it's not as though, this 80 that we talk about, it's not as though it has no stress on our system. This has had major stress on our hospital systems today. When we go over it'll be about 1,500 cases, then every bed in the hospital is taken. Every single bed that we have in the city is taken because we have other patients who need care. We have a total of about 2,400 beds in the city and metro area. And so if we get over that threshold of COVID cases, every single bed in the hospitals. But when Lauren talks about surge capacity, that's doubling up beds, that's leaving people in the emergency rooms, that's using hallways to some extent to get to that surge capacity, opening up wards that are shuttered today because they're unfinished, those sorts of things. So that already, getting to surge is a major issue for our hospital system. When we go from all beds filled to surge, Lauren's mortality rates stay flat, but that won't be the case. When we get to that point, the rates of death in the hospital will be much higher because you just can't provide that same high level of care that patients are getting today. And as soon as you exceed that, then you need other buildings. You got people at the convention center, the Irwin Center, they're evaluating a bunch of different places for that. And then your mortality rates go sky high. That's not really reflected in the model. So just to be clear, that threshold is really critical. Those thresholds are really critical for how we can care for people. And there are things that we on the healthcare delivery side lose sleep over because we do not want to be anywhere close to in those positions. So that's going to make us a little nervous about some of the projections and relying too heavily on them as we start to see hospitalizations go up. Again, we've gotten nervous at 80. We're going to be really nervous at 500. So whether we can actually stomach a curve like Lauren showed in our optimizations or not is uncertain. And I think we'll have to sort of watch carefully and consider and think and see. And but the issue of preparedness is absolutely critical. Okay, so now I want to move to a different topic, and that's one of the ones that Lauren talked about being prepared for. So currently we find out we do better testing than we have before. We actually are not fully utilizing our testing capacity in the city right now. There are multiple places where people get tested, people still who need to be tested are not being tested though. So there's a disconnect between that availability and who's getting tested. And then we do contact tracing for that group. Now our contact tracing has been okay, but needs to be better. So, for some of the contact, it's just an extremely complex task and requires us really understanding where the cases and clusters are coming from. That should be data that we're sharing. We're not quite to that level yet. We need to be up to that and elevate the bar for how that's done. With that, we can understand where we're failing and where we're succeeding in terms of controlling disease. We don't have a good sense of that today, as good a sense as we need. And then I want to move to the cocooning notion. Lauren and the mayor both made points about this. We have incredibly vulnerable populations. So the nursing home population in particular is shockingly vulnerable. So about 2/3 of our deaths are from people who had lived in nursing homes. 2/3. And that's just unbelievable that how vulnerable that population really is. In every country, every city across the world, the same has been the case. No one seems to have figured out how to do this. Certainly what we're doing today is completely inadequate, and probably what would appear to be obvious or reasonable incremental things are going to be inadequate to that population. How much do we really need to invest? We don't know, but we need to invest a lot more if we want to reduce our deaths and reduce our deaths and also allow for capacity when we're going to need it for all the different folks who are going to need hospitalization and ventilators as we move forward. Another important population is the homeless. We've had an outbreak in town. It happened at the Salvation Army, quickly moved in, dealt with that. So far, Arch is okay. We've had some cases around there, but no major outbreak. That group is at extreme risk, and that needs to be addressed. And then the other group are the working poor. So we've forced, it's not forced, but economic conditions have pressured folks to continue to work in places where social distancing was not possible. And that can include things like construction, but also in the workers in our nursing homes. Also the workers in other frontline food industry. And we know that group is particularly vulnerable and has been affected. So on that count, again, looking at hospitalizations, knowing that we don't have all the data from testing, we know that about 44% of our hospitalizations are Hispanic versus about 26% of our population. For African Americans, it's 10% hospitalized versus 8% in our population. And then just to put that in perspective, a third of the hospitalizations are non-Hispanic white versus 46% in our population. So we're already starting to see the race ethnic disparities that have been documented across the U.S. We're going to need to track that and think about how to deal with these through policies that protect, not necessarily cocoon for these populations, but protect these populations and the settings in which they work, because they have certainly helped us at a societal level, and some of them, in being out in front and continuing to get the job done for us. So those are, I've got to say, just to finish up, this has brought out some of the best in our community. The way in which folks are working together to address this has been really remarkable. In how quickly we've moved through what used to be horrible policy issues and legal concerns in order to work together has been remarkable. There's still more opportunity to move faster in that area. One area that we're frustrated with on this side is, even though we're getting a ton more data than we ever would have hoped for before, we're still not getting the kind of data that one would like at a multi-county level in particular, to really be able to respond, to look at high-risk groups, to be able to respond with the data quickly, and to change course as we go. So that's it for my comments.
Dr. Johnson, thank you very much. Dr. Escott, you want to give us any high-level thoughts as well? And I want to give council some time to be able to ask questions of you and the others. So,
yes, I will. I'm going to ask the IT folks to pull up my slides. I'll go through some of those very quickly. Some of the points were already made. While they pull that up, I want to pick up on a few points. And first, I'd like to thank Clay and Lauren, as well as our other healthcare professionals that have been working closely with us. I think we have a spirit of cooperation here that has helped make informed decisions, and they've all done a great job, and I certainly appreciate their partnership. A few things, as Lauren's model described, we really do want to avoid that surge past capacity in the hospitals. And not only is that going to result in excess deaths from COVID-19, but there's going to be a mortality impact on other things like strokes and heart attacks and accidents. So we have to be cognizant of the fact that we really must avoid that surge past capacity. There are some other elements that we're also looking into to better inform those models. And one of those is the normal surge that we see during flu season. We are waiting on some data from our hospital systems, but there are excess normal hospitalizations, normal surge as a result of flu and other things during the fall and winter months. On bad flu seasons, just at one hospital system, that may be up to 700 or 800 additional hospitalizations on a weekly basis. On lighter flu seasons in one hospital system, that's more in the range of 150 to 200. So that is a factor we're looking at. As Lauren said, we're going to have to fight this battle at some stage. We want to be best prepared and best informed on when the right stage to fight that battle is. Some other things that are going to be critical as we move forward and look at how we deal with this are things like identifying effective treatment and vaccine. Those two things can substantially impact things like closures and hospital surge, and something that we just don't have a great timeline on now, but maybe substantial factors. The other big thing that's going to help us this season is flu vaccinations. So we are going to have to be quite aggressive when it comes to vaccinating folks for the flu, so that we can mitigate that risk of flu surge in the midst of this COVID-19 battle. Can you pull up the next slide for me, please? IT? There we go. All right, so this is just a regular dashboard. I'm going to skip past this one.
There seems to be a slight
already...
delay in what you're viewing. Sorry.
Okay, that's okay. You can go to the next slide.
we see the two pie charts, Dr. Escott.
Okay, beautiful. So as Clay mentioned, the question has come, is this the right timing? And as Clay described, we are seeing this is some data based on hospitalizations and discharge up through April the 22nd. And we see that particularly on the graph on the left, the Hispanic population is overrepresented. On the graph on the right, we see that our Black community, who is 8% of the population, is overrepresented on hospitalizations. We're going to update this week, and we expect these numbers to substantially increase as we look at current hospitalizations. So, as was discussed by Clay, we really are not at the stage where we've got control and have appropriate outreach to these higher risk communities to really turn on the switch effectively at this stage. Next slide, please.
We can now see the line chart.
Okay, beautiful. So what you're seeing here is a graph of three things. The red is the cumulative numbers, the yellow is change in cases by day, and the green is the percent change compared to the previous day. And this is on a logarithmic scale. So you can see that we've had a positive trend as far as increases in percentage per day, which has shown our doubling rate go from 2 days to a little more than 15 days right now. So this is a positive trend, and we're pleased with this. Next slide, please. On the next slide, you're going to see that that when we look at cases by week, and I showed this last week, the one on the far right is from the week that ended on Saturday of this week. So we see that we do have the first week of decreasing number of cases in our pandemic here in Austin, which again is also positive, particularly as we've been increasing testing. I will say that with our public enrollment process, we're testing 800 people in the next 7 days. This is about equivalent to what Austin Public Health tested in the previous 30 days. So this is one component of the overall testing that's happening across our community. We have partners at Community Care. We have partners at Dell Medical School, at a number of different establishments across the city and county who are also doing testing. But we are refreshed that the barriers are coming down for testing and that people have improved access to get those tests done in a rapid manner. Next slide, please. As we look at the comparison of Travis County versus the other metropolitan counties in the state of Texas, we again this week see that the Travis County is doing well per capita when it comes to testing, 8.1 per 1,000. This is based on the CV19 lab testing dashboard accessed yesterday. When we look at testing in the past 7 days, Travis County is doing well as compared to those other metropolitan counties at 1 per 1,000 in the past 7 days. Again, we want to increase this substantially so that we can have better surveillance and better timely surveillance when it comes to testing in our community. Next slide, please. One of the things that is a bit more confusing is the percent positive. We've referred to this before. The federal government and the state government have referred to this as a benchmark for how we're doing. And, we're still at 9.6% according to the same data source as compared to other counties like Bexar County and Harris County, which have a lower percentage, despite the fact that we have a higher per capita rate of testing. So again, this is higher than we want it to be. We want this to be closer to 5% positive, which will give us an indication that we are testing enough people to effectively identify new cases, do the contact tracing, and isolate those individuals. Next slide, please. And finally, I want to touch on what Clay also mentioned, and that is our issue in relation to not only nursing homes, but also long-term care facilities and other institutional settings like shelters. You can see from this graph, we've de-identified the particular facility involved, but you can see here that we have a total of 280 individuals in these facility settings that are COVID-19 positive. When we look at residents, that's almost 200. When we look at staff, that's 88. And again, as Clay mentioned, this represents 2/3 of our deaths in the nursing homes and assisted living facilities alone. So this really does reinforce the message that we have to do better. We have deployed strike teams that the state has funded to 3 facilities here in Travis County. The 4th strike team has been redirected to Williamson County to help with their nursing home outbreak that they're seeing. But we have additional needs in regards to better protecting those facilities who already have outbreaks and protecting those facilities that don't have outbreaks. We do strongly believe that we need across the board increases in staffing, improvement in practices at these really vulnerable populations so that we can substantially impact that death curve associated with our COVID-19 pandemic. I'll stop there so that I can take questions and turn it back over to you, Mayor.
Thank you. And Dr. Escott, you said you had to leave at 10:30 because you have to head over to the Commissioner's Court.
Yes, sir.
Dr. Myers and Dr. Johnson, how much time do you have?
I can stay as long as you need.
I'm sorry?
I can stay as long as you would like.
Great, thank you.
I need to leave at 10:30. Sorry.
Sounds good, thank you. Colleagues, I'm going to open it up now for questions that you might have and you want to ask. Ann, you want to start us off?
Yeah, I have a lot of questions, but I'll be short given there's many of us and not a lot of time. So, I'll just ask Dr. Escott a few quick questions. And Dr. Escott, I'd like to talk with you more later. I know we have a social service cabinet meeting this afternoon. Perhaps I can talk to Stephanie about, I have a lot of questions about the nursing facilities, so I'll just ask two of them. The first one is, are we testing all the workers in the facilities where there are clusters? Have we completed testing? Two questions. Are we testing all those workers, and where are we in terms of completion? I know that the order, and I really appreciate the order that you issued about a week ago. It was really very helpful, but I want to know the status of that. Have we completed testing in any of these facilities?
It's a great question, Council Member. We have completed testing at one facility. This week, we're in the process of rolling out testing at the other facilities that have outbreaks. Again, up until last week, we're really not in a position with availability of testing to do widespread testing of staff and residents. As that capacity is improving, we're going to continue to improve our ability to test both the staff and the residents at these facilities. And this will be one of the functions of the strike teams who've been deployed, is to do more aggressive testing at these facilities.
Okay, so one follow-up question. Then when we've completed testing at only one facility, that's only testing of the workers, right? Not the residents?
That's correct.
Okay. I have a lot of questions. I'd like to see the data that, thank you very much for providing the data that you did. That's very helpful in that chart to help us have an understanding of the level of the problem and the risk. Can you please provide that data? I assume that data is a point in time data as opposed to cumulative. Is that correct?
That data was as of Sunday.
Okay, cumulative as of Sunday, I assume?
That's correct.
I would like to ask for some data that shows us the trend. And you don't have to answer that now, but I'd like to see the trend so I can understand the degree to which it may be getting worse in particular facilities. I'm going to ask one more question and then let my colleagues ask questions. Let's see. If I'm understanding correctly, the status of the strike force teams, and these are the teams that you had described to us before, we only have them in place in 3 of these facilities. Can I assume that it's 3 of the ones that are on the chart that you listed for us?
Yes, and again, the numbers I showed are cumulative. Some of those facilities do not have active spread at this stage.
Okay.
Yeah, we would like to deploy more teams so that all of the facilities with active spread and active clusters have the availability of that strike team. One of the things I want to point out is that up until this stage and the support from the state, that one of the challenges has been because of the staff impact, these facilities end up understaffed, and that just perpetuates this exponential growth of cases within the facilities.
Okay, and we'll come back to you if we can.
Okay, that's fine. Sorry, guys.
It's okay. Natasha, and then Greg, and then Jimmy.
Yes, thank you. Thank you, Councilmember Kitchen. I appreciate a lot of your questions. I shared similar concerns. Real quick question I have. Dr. Escott, you said that we have to increase our ability and execution on education and outreach for at-risk communities. I just wanted to gauge from you what exactly it is that you think we should be doing differently to ensure that communities that are at higher risk are informed. So my office, for example, is working on a pilot where we're attempting to distribute educational information and information about resources, but to the degree that we are able to do it on the ground as opposed to exclusively digitally. So I guess I'm asking your advice, what more could we do to extend that education, outreach, information, communication to these populations of people that you made reference to?
That's a great question, council member. Let me say that community care, as well as our social services branch, are probably the better ones to coordinate those outreach efforts. They can better identify where those current gaps are and those needs are. I think that as a result of the governor's actions, and I will say I'll agree with the mayor that this is a bit too soon for us. As we're still preparing the contact tracing, as we're still ramping up testing, as we are working to protect the most vulnerable populations, as we are advancing our initiatives to reach out to those vulnerable populations, now's not the time to flip on the light switch. So, I think reaching out, I know community care is doing door hangers, they're doing mail outs, phone calls for those who may not be as digitally inclined as others. I think the critical thing is that folks need to understand the symptoms. They need to understand that we've moved past the cough and the shortness of breath. We've moved into a phase where we want to be concerned about sore throats. We want to be concerned about changes in smell and taste. We want to be concerned about chills and rigors or the shakes. These are all symptoms that are consistent with COVID-19. And the moment that somebody starts developing those symptoms, the same day, we want them to sign up for testing. We want them to be tested within 24 hours. Ideally, at some stage, we want to be able to test them the same day and get them the results the same day. The better we can achieve that goal, the better control we're going to get over this particular issue. I will say the other big thing, as was mentioned earlier, is that the same population that's more vulnerable is the same population that we're sending back to work. They're the low-wage earners. They're the ones who are going to have a large number of person-to-person contacts, which is at the heart of Lauren's modeling. And we have to make sure that those employees are not just doing a job to create revenue, but they are protected also at the same time. I really can't stress this enough that it is irresponsible for us as a community to send folks to the front lines. And we had this conversation about healthcare workers. The same is true for cashiers. The same is true for registration clerks. The same is true for all of those who have a public-facing role, that we have to provide them protection. Their employers have to provide them protection. If they can't provide it right now, they should not be opening their doors.
Okay, thank you. Greg, and then Jimmy, and then Allison.
I have two really short questions, and then my third point, I think, goes to Dr. Escott's last point here. My first one is for Dr. Myers. Thank you for everything throughout this. When you have the two graphs that show 2,900 deaths, one with the hospitals being catastrophically overrun, and one without that overrun, it seems odd to me that the number of deaths, or counterintuitive to me that the number of deaths is the same. Is that because it's the same number of COVID deaths, but we aren't counting other deaths caused by the hospital being overrun? I know you mentioned it briefly during your remarks, but could you clarify that a bit for us?
Yes. So you're right. Your intuition is right. In that first scenario where we have the hospitals overrun, we would actually expect more COVID-19 deaths and probably more deaths from other causes because people are not able to get effective treatment during that overrun period. We have just not explicitly accounted for that in the model. So the model assumes that anyone who ends up in a hospital at any time, whether you're over capacity or under capacity, has the same chance of dying from COVID-19. So that is probably underestimating the catastrophic impact of exceeding our capacity.
Right. So if we don't want a catastrophic overrun of our hospitals and potentially even more deaths than those 2,900, then the second lockdown might be necessary. And then or would be necessary, and I would support it. My second quick question is around the word cocooning of vulnerable people. That means, for example, somebody with a serious respiratory issue not going to a frontline job, even if they've got a mask, not being a cashier and going into work every day. Is that cocooning? Or cocooning would be that person not being a cashier every single day.
Yes. I mean, it can mean a lot of things. And I think Dr. Escott and Dr. Johnson both spoke to some of these, but it's basically everything you can do to keep people who are over 65 or people who are younger with known high-risk conditions from coming in contact with other people. So if that means having them stay home from work if they are employed in a way that requires, direct contact with people. I mean, it means actually first and foremost, taking care of the very high risk explosive situation we have in our nursing homes. And we've already spoken a lot about this, but in my opinion, these strike forces are absolutely essential to contain transmission once you have an outbreak. But equally important is putting resources in place now, including increased in different kinds of staffing, so that we prevent the disease from ever arriving in these nursing homes in the first place. The problem is that once it gets to nursing homes, the transmission is just amplified so much because of the nature of the daily contacts between the caregivers and the residents. And in fact, my very first paper I ever published in infectious disease epidemiology was a paper that I wrote with the CDC back in the year 2000, which was about how do you contain outbreaks of silently spreading respiratory diseases in long-term care facilities like nursing homes. And the difficulty is that the people who work there, who may not be able to afford to stay home from work and may be relatively young and healthy, so may not even know they're infected when they're infected, they come to work. They not only, what I've heard in Austin is not only are they interacting with maybe a dozen or more residents in one nursing home, but they're moonlighting in a second nursing home, right? So we have a situation where by the time a strike force gets into a nursing home, it is probably too late to stop at least, a big part of the transmission. So, thinking, and this is what, buying us time does, is thinking about how do we resource nursing homes right now preventatively and not just reaction, reacting to outbreaks.
And it seems like your model anticipates that we will have to do a second lockdown, and that we're facing 2,900 deaths potentially, even in a situation where we do a lot. But what you're saying is the difference potentially between 2 lockdowns and 5 lockdowns, or the difference between 2,900 deaths and 6,500 deaths, is how well we do cocooning that vulnerable population. And I know we're working really hard on homelessness. Sounds like there's all of this important work to be done on nursing homes. But my third and last point here is all of those other folks that have underlying conditions or are older that are being called into work. I think we need to really accelerate the conversation about what we do to protect those people and those workers' rights to have the opportunity to stay home. I'm going to throw up a message board post just with some sets of ideas for the council, the manager, and folks to start responding to. But, if you are called into work at a cash register and you have one of these underlying conditions, you're put in the impossible choice of, do you quit or do you put yourself at risk? And even though there is special pandemic unemployment insurance in some of those cases, that requires that you get a special doctor's note. And we have lots of these folks that don't have a doctor, don't have health care. Of course, lots of immigrant communities are left out of that special pandemic unemployment insurance. So I think we're going to be in a situation where we are in a situation where there are going to be thousands of these people who are trying to cocoon. But if they don't have the ability to stand up to their employer and exercise their right, or they don't have a doctor to get that letter from, we need to be thinking about how we retrain those people for telework, how we keep those folks home. But I don't think we've got that set up right now.
And when the experts leave, we have a chance to talk amongst each other. Let's stay if we can. Questions for these people.
I just like to explain one more thing, if you don't mind. Sorry. No. So you talk about these 2 scenarios. We're either going to have this many deaths or that many deaths. I showed you 2 scenarios. There are. Just to be clear, I don't think we can't necessarily forecast that we are going to have this many deaths. There is also the plausible scenario that with the relaxation of social distancing, we actually reduce transmission by 80% instead of 40%, and it's somewhere in between. So these are plausible futures, but not the only plausible futures.
That's really helpful. Thank you.
Okay, thank you. I think it was Jimmy and then Al.
Thank you. And those were a lot of the questions that I had written down too. So one that we haven't talked about yet, and it speaks to this difference between 40 and 80%. What does it look like as some businesses decide to reopen? How much information do we have about the effectiveness of techniques businesses can use if they open, either under what the governor has defined or in any condition? I'm already seeing some business owners on social media talking about opening next week, restaurants, for example. Do we know, is there data that shows if the employees wear masks but the customers don't, if the customers wear masks but the employees don't, what percentage of people are wearing masks? How is there data that shows what are the most critical pieces or not?
Dr. Escott?
Yeah, that's a great question, council member. You know, all we have as far as data for this outbreak is what we've already collected to this stage. We see a lot of different policy experimentation going on, and we may have better answers to those questions in the next month, 2 months, as more data happens, as different cities and jurisdictions do different things. I will say that, as Lauren and Clay both mentioned, you know, even with the grocery stores and hardware stores and some other places open at this stage, we've still been able to maintain a 90 to 95 effective social distancing. So that indicates to me that some of these interventions are working. They are successful. When we look at things like decreasing the capacity of the occupancy in the building, when we look at spacing out customers, you know, we've seen lines at H-E-B and Target and many other stores where people should stand. When we look at some of the interventions that some have done by putting up the plexiglass between the cashier and the customer, I think the data indicates to us that some of those things may in fact be effective. And, you know, these are some of the conversations we're having with the Austin Chamber and the task force, is to adapt some of the things that we've seen working to businesses that are now starting to look at opening up.
All right.
And the tough part, Jimmy, is we don't have good studies and we don't know. We have anecdotal stuff. We're not going to know what the governor ordered. We don't know what that's going to do until we actually see it. That's why we have to watch it and test for it.
But to be clear, the governor's order doesn't require businesses open unless it also threatens the ability to access resources through the CARES Act, or it threatens the ability to access unemployment. Those are some more questions we're going to have to dig into.
Absolutely. Allison.
Thank you. Good morning. I have some questions, I think, that are for Dean Johnson and for Dr. Escott. I'm concerned about better understanding what we're doing for contact tracing, and we've talked a little bit about how we're increasing testing, but I'm hearing from a lot of constituents who are in the medical profession who have thoughts and ideas about how we could be bootstrapping up our contact tracing with artificial intelligence, or doing our testing differently using saliva. And there's a lot of different ideas that are circulating, and it seems like solving that problem of how to really improve our contact tracing, or to improve our detection, whether it's saliva testing, whether it's temperature testing and other kinds of stuff. We haven't talked about that a lot. So if you could speak to that, I would appreciate it.
Sure, I'll start, then I'll have Dr. Johnson come on if he's still available. So first of all, we're seeing lots of new technologies come out in relation to testing and contact tracing. That's going to mean that we're going to have to continue to change strategies based upon that new technology. The saliva testing has recently been FDA approved out of a lab at Rutgers, I believe. And we expect that that's going to transition to a primary source of testing because it's likely to be cheaper and easier. It's likely to allow us to do batch testing, which we've seen to some extent with the current PCR testing with the nasopharyngeal swabs, which will give us faster results if you can group a large number of people together. And that's important in situations where you have a low prevalence of disease or active disease, and allows you to quickly screen people. Regarding our current contact tracing efforts, last weekend we introduced this Salesforce platform to not only schedule people for testing, but also to semi-automate the contact tracing piece. So if somebody gets a positive result, they get a questionnaire, they get asked where they've been, who they've had contact with. So that takes out some of the person hours needed to call them on some of those. We still have to use people to fill in the gaps, but that is a positive method for us to build upon. In fact, part of the state's plan is to utilize the same platform statewide, after discussions with them, so that we have seamless contact tracing across the state. In addition to that, the state is ramping up the personnel. I think the number I saw is 4,000 personnel to support that contact tracing, that semi-automated contact tracing process. We certainly have additional capacity within Austin Public Health for contact tracing if we need to add more people. And certainly our partners at the University of Texas Dell Medical School and Community Care have been involved in that contact tracing piece already and also have the ability to expand. There are a number of technologies which are available, which we are looking into. There's a product by Apple and Google to ping phones to give us proximity. So I can identify folks that were in close proximity to those who have a confirmed case to alert them. There's a project out at MIT and Harvard, which does something similar. So we're looking at all these technologies to see if they are effective and also to understand the civil liberties issues that may be associated. When we look at Singapore, who's utilized some of this technology, about somewhere between 12 and 20% of folks have signed up for this app that allows that pinging process to happen. In their estimations, they would need 80% of people with phones to utilize that app. So the technology's there, it's building, but the applicability is still yet to be seen. Obviously, if we can't get to, in Singapore's circumstance, 80%, you can do a lot of pinging, you can invest the resources, but if it's not going to result in a substantial impact, then we've got to reevaluate other potential issues. But we are looking into those, and we certainly want to continue to hear about new technology which may be available to help that process.
Thank you. Dr. Johnson. Dean, you want to?
Yeah, so, and I can stay on for a few more minutes. I just moved my next meeting. So as Mark mentioned, there are a bunch of approaches that we need to be thinking about, and we definitely need to ramp up the testing and contact tracing to effectively control what will be clusters that are going to happen over the next few weeks to months. The approaches, the electronic approaches that were described, we are definitely talking to those people. We're talking to the people at high level, and at MIT, that's actually a platform that sits on top of the Google Apple platform. But again, it's going to be a kind of opt-in thing. So how effective that's going to be, we're not certain. The human touch is really critical for this. Understanding the connections between people and talking to people, and also using that as a basis to tell people, no, you need to be isolated, and then finding ways to isolate them. That human aspect is really, really important. We think that's going to require more personnel and more attention to this. We also need to set common standards. So on the UT side, we have traced something like a quarter, maybe a few more of the total contacts that have occurred in the city. So we've set standards so that we, as much as possible, try to reach them within 2 hours, but always within 24 hours. And we've reached 95% contact tracing, which is very high. I mean, it's really hard to find people and all of that. That requires shifts and people working on weekends, and then we have to gather that data and actually represent it so people can act on it. One of the key pieces isn't just the individuals who are affected, but it's also what that means in terms of construction work as being a high-risk area, or restaurants as being high risk, or religious institutions being high risk. And that's something that they've done very, very effectively in Singapore that we can do here. So I think our hope is to continue to work with Austin Public Health to build the IT platform for this, but really to set those high standards and to achieve them on a local level for you all as policymakers too, to help us to control risks in these targeted groups.
Thank you. One other question I had is we've heard obviously about the unfortunate clusters in the nursing homes and with respect to the deaths and with respect to those cases, but can you tell us more, either Dr. Escott or Dean Johnson, about the population that we're seeing testing positive, and are these people who were overly exposed, or were these people who just went to the grocery store and got infected? What do we know about where the risks are lying in the cases that are newly positive and beyond the hospitalization or the deaths in the nursing home?
We may have I'm not sure if we still have Mark on. I mean, I can start. Initially, it was more in travelers, people who were connected to many people. We saw that for the UT clusters. There were 2 of them actually, the from the president's office and then for the Cabo the spring breakers, 2 giant clusters. But then more recently, we're seeing, and we need better data on this so that we're sharing it, but we're seeing more construction workers or families that live in close proximity. A lot of family clusters. We had at one point three people from the same family hospitalized. A family that lived in East Austin, where 1 was a construction worker. So those are the kinds of things that we have today, but we're not yet aggregating this in a way to make it actionable. And so that's a critical need right now. Mark, you should add.
Yeah, definitely. I agree with what you're saying. And part of moving to this new platform is to better be able to aggregate that data, not only for Austin and Travis County and with the medical school, but also Williamson County and the surrounding counties. Part of the challenge that we've had is the one that Clay mentioned earlier, is there are jurisdictional boundaries. I'm only entitled to the data for people hospitalized or residents of Travis County, but we know that 30% of our workforce comes from another county, which makes that contact tracing challenging, which makes us more challenged in controlling the outbreak. And this is why we encourage the state to utilize a statewide platform, a statewide data sharing, so that it will make it easier for us to better do this contact tracing and piece together the elements. Again, as things start to open up, contact tracing becomes more difficult. As Clay mentioned early on in this process, we had some cases that had hundreds of contacts, other dozens of contacts who traveled to multiple businesses. Over the past several weeks, the contact tracing involved 1 or 2 people because primarily people were still staying home. There weren't businesses for them to go to other than grocery stores or hardware stores. So as we start to reopen things, that contact tracing will become more challenging. It will take more hours and more people to do that because of that increased number of contacts that are going to happen. So I agree. We have to start aggregating that data better, and we're hopeful that this statewide platform that's expected to launch next week will help us to do that.
And let's continue moving on.
Can I just add one thing for Dr. Escott? I think it's really important. You mentioned something in your remarks, which I hadn't heard before, was that you wanted people to go get testing as soon as they had one of the symptoms. To date, what we've been hearing is you needed to have the cluster, you kind of had to know that you were sick. And I think that's a shift in messaging, and I hope that you'll work with the PIO to help us amplify that, because we didn't have the testing before to do more, but I don't think people know, like, I get a sore throat, I need to call about testing. I'm not sure that message is out there properly, so if you could try to underscore that with PIO so we can get that information out, I think that's really important, a change due to the increased capacity.
Thank you, Councilmember Alter. Councilor Ellis, and then Mayor Pro Tem Garza.
Thank you. That dovetails nicely into a question I had, which was that Dean Johnston was saying that we were not fully utilizing testing capacity. And then I know that Dr. Escott said that our testing was high per capita. So I wanted to get a little more clarification on, is it that we have testing capacity that we're still trying to manage the procedural process for that so that we make sure we have enough for healthcare workers and first responders? Or is it a matter of not knowing when the next groups of tests are coming or what types of tests will be available? Can you talk a little more about that?
So I'll start, and then the dean can jump in after me. Again, our ability to test all symptomatic patients, just started a few weeks ago. Before that, we were more restricted because we weren't sure we had enough for healthcare workers and first responders. Now we're transitioning into the phase where we want to lower the bar further because we have more capacity. Having said that, there is still not plentiful enough capacity to be really comfortable with our testing strategy. in a conversation with our expert panel last night and our hospital CEOs, we don't have enough capacity to test everybody who's admitted to the hospital. We don't have enough capacity to test every resident of every nursing home that comes into the hospital. So we have a long ways to go. You know, I'm happy that per capita we're doing better than other metro jurisdictions, but we're not even close to where we need to be. We're talking about 2,000 tests a week. We need 2,000 tests a day to really be in that position to be more confident in our ability to detect disease quickly. And again, we are expecting that as test availability improves, the technology will also change. We'll likely move to quicker testing, which will give us more timely results. But obviously, the shorter duration that we can get between when the person first develops symptoms and when they get tested and when they get a result, the better ability we're going to have to control this disease here.
Yeah, and just to clarify, that, I mean, that way Mark said it was perfect, but we have more capacity on a daily basis than we're using today. But that's not because we have enough to test all the people we'd like to test. We're just not getting the right people into the testing settings that we need to get them into. And APH has actually done a great job of trying to get that message out, but it always lags. And it's still not perfectly convenient. And even some places where it should be obvious that you should get testing, you can't. You can't from your primary care doc. You can't from, if you're going to, have a surgery, you can't get it from that. But even in many emergency rooms, you can't get it. And so we've got to make sure the conduits, the easy conduits, are available to people for testing. And then we have to make sure the message is out that the right people get tested. And then we can start to expand the breadth that we really need to for those who are eligible for testing.
That's extremely helpful. I appreciate that. And how well is our portal doing? Do we have a number of the people who have qualified for testing versus the people who have applied for testing? How well is that working? I'm really excited to see that that's up and running.
So I don't have the number of people accessed in front of me. I know that we've scheduled 800 for testing between when we started this Saturday and over the next week. Again, this is a constant process of reminding folks when we've had outreach from the healthcare community, when we've had outreach from churches and other groups, what can they do? Part of that answer is encourage people to access this site, encourage communities to go and at least fill out a questionnaire. Some folks who've gone to the site, have just been curious and want to see what it's about. But right now, everybody who's symptomatic is getting tested, and we're pleased with that. This is about a 4-fold improvement on daily testing as compared to when we had the process where folks had to go through a physician to schedule that testing. So we're very pleased. We'd like to see it improve even more. And we want to make sure that people understand that even if the symptoms are mild, even if it's just a slight sore throat or a temperature of 99.6, we want them tested. We want them tested early because generally it starts early and sometimes it progresses to more serious illness. If we can diagnose early, we can monitor that individual better. We can give them advice if they're getting worse, which is part of what this semi-automated system does, so that we can advise them, hey, you're getting worse, go to the hospital. You need to be seen there and treated there. The better we can get control of this situation here.
I appreciate that, and I appreciate the news flash that came out regarding that site, because I think a lot of my colleagues and I all tried to get the word out as soon as possible. So I want to extend my thanks to you on that.
All right, thank you.
And to the city manager.
Mayor Pro Tem Garza. You're muted. Still muted.
For Professor Myers, but first I just wanted to point everyone to the daily PIO emails we get, and they have really been trying to push that information out. In fact, they have links to the press releases they put out as well as what they've put out, and quick links and they've actually asked us to help with that spreading of that message, including links for Facebook and Twitter, et cetera. So they really are trying to get that information out there about the new testing regulations. But for Professor, was it Meyer? I'm sorry, Professor Meyer, is that right?
Myers. Yeah.
Myers. Professor, the first graph you showed shows the social, like if we were to stay the course that we're on right now, and it looks worse only because it's a magnified, and so when I first looked at it, I was kind of, but then when you look at the other three graphs, it's actually, if the other graphs are, doing this, it's actually it would be way down. Is there a way, or could you provide that graph with both of those that show, as we try to, each of us has newsletters or does, and I think in the very beginning, I think it was your graph we were able to share that showed the different scenarios, and I got a lot of great feedback from people, giving them the visual of understanding the different scenarios. Would you be able to provide a graph that shows if we were to stay the course here, and the same graph showing when we put in these different when we loosen regulations and allow that flexibility, how that changes? Could you do that?
So you're saying, in addition to these graphs, you want to see one that is to scale, so you can see how much lower that curve really is on the top one versus the bottom one. Yeah, yes. That's something we can update this report, so maybe it's clear as sort of an inset or a magnification of a graph to make that clearer to your constituents. Sure.
Okay, thank you. And then just lastly, the mayor mentioned that I guess you were advising even the White House and the state, and so I just want to be clear that they have this information and this data, and no. Okay.
No, I mean, so we've been doing a lot of modeling. If you go to the UT COVID-19 Modeling Consortium website, you'll see we have reports, we have papers on, and we're doing sort of modeling by request. And we are working absolutely most closely with Austin, more than any of the other sort of policymakers at any scale. And so a lot of these kinds of reports are really grounded in Austin data and in kind of daily, weekly dialogue with the decision makers, and you guys. And so, but however, like last week, or maybe it was 2 weeks ago, we got a request from the CDC that is basically asking the exact same kinds of questions that city leadership in Austin are asking. And so we will probably very soon make a national version or projection based on this and share that with the CDC. With respect to the state of Texas, we have not had that much direct interaction with them, although we have provided, at least early on, we were providing similar projections for 22 cities around Texas, one of which was Austin, but we have not been engaged on a regular basis in the same way that we are engaged with the city of Austin. And they, for example, have not seen the graphs that I showed you today.
Okay. And then just unequivocally, we know that, is this correct? That 14 days is not enough to really show if there is a trend of some sort in new regulations.
Yes, that is unequivocally correct, right? I mean, particularly now with the kind of data we have at this point. We are the best data we have, the really most reliable data we have are hospitalizations, and we really do have unprecedented access to local hospitalizations. My modeling colleagues around the country are trying to do similar things on different scales, and they are not able to see the same quality of data that we are able to see here in Austin. But if you look at, so there's a couple of reasons why we won't know for several weeks whether transmission has really ramped up. One is that just the nature of epidemic growth, it takes a while. There's a sort of flat period before it starts steeply increasing. And you can see this in some of the graphs, like if you look at the top graph in figure 2, you'll see we've relaxed things on May 1st, which is the end of that stay home, work safe period. But then it really, there's a good month before we start seeing an uptick, right? But on top of that, there's this delay between, we want to know how many people are being infected today, but we won't see a signal of that until those people who are infected today, those who are going to end up being hospitalized, actually show up in hospitals. And so that's, probably a week and a half, 2 weeks. And then you actually need several days of those people to see, is the trend changed from, down to flat to up. So it's really, I think really to get a good signal, it's 3, maybe 4 weeks, given the data we have access to today.
Okay. Well, thank you so much.
I agree with that. And that's one of the elements that the mayor and I have discussed you really need 2 weeks to start to see that change, and then another 2 weeks to see the trend and understand the impact. I'll be clear that the strategy of going from 25 to 50% is something we've been discussing for months now in the expert panel as a potential strategy for reopening. But the time we're starting is too soon, and the time for reassessment of those phases is too quick. We really need to stretch it as much as we can. We've been preempted to some extent from the governor on some of those decisions, but effectively as a community, we have to still embrace Lauren's models as well as the advice that we really need to continue to stretch this out as much as we can.
Thank you. Councilmember Tovo.
Thank you. These models are very, very helpful, if grim. And so I wanted to drill down on some of the things that you were just discussing in your response to the last question. And because of the governor's decision, we're really looking at scenario 3 is kind of our best scenario at this point, it would seem to me, where that choice about social distancing, relaxation has been made for us, but we're doing everything as a community we can to make it as safe as possible for those who are out in those public spaces. And so I wonder if you could, and just to be clear, that in terms of the models that it responds to, those are the ones that look at page 5, that appear on page 5 in figure 1, the bottom, as well as on page 6. Those all respond in some way to the different, to relaxation under different conditions, cocooning at 80% versus cocooning at 90%. Can you help me understand the difference between the bottom model on page 5 and the top model on page 6?
Sure. So, and let me just, I want to restate something I said earlier. So this is 2 possible scenarios of, either we maintain 90% or when we relax, we go down to 40%, and we could be somewhere in between. So
absolutely,
under the assumption that relaxation means we're going to, we are only blocking transmission about 40%. The difference between the bottom figure of figure 1 and the top figure of figure 2 is that in the bottom figure of figure 1, we are assuming that we are not going to initiate another stay-home lockdown period. We are saying we're going to let this thing go no matter what happens, and what would happen if we just allow relaxation indefinitely. So this is just showing why we probably will need to take additional action, because if we don't, we have this catastrophic surge in healthcare capacity. As we discussed before, probably even more deaths than we're projecting here. And then on top of figure 2, we're saying, okay, if that is the future we're looking at, that on May 1st, we're going to be relaxing social distancing to the extent that we're only reducing transmission by 40%, and we want to ensure that we don't exceed hospital capacity, what top of figure 2 says is it is showing the optimal sort of strategy for doing that under this scenario. And optimal meaning it ensures that we don't exceed capacity, but it also does so using the fewest days under lockdown, the fewest future days where we have to go back into a stay home, work safe mode. So, and what it's telling us is that, if we, best case scenario in this scenario, that we would have to undergo one more, approximately 3-month period of stay home, work safe towards the, middle to the end of the summer. And then that should be sufficient to avert a catastrophic surge in hospitalizations. Now, let me just say, we would be in a better situation, even though you don't see it in these graphs, if we are, as communities are actually able to block transmission, better than 40%. So if we go into relaxation and people comply and they comply with recommendations, they really, take extra steps, testing, tracing, isolation of them, we might be in a scenario where relaxation actually means 80% reduction. And And then it would look different than the graphs I'm showing you here. And I'm not showing you that scenario.
Yeah, thank you. I think your graphs really illustrate on what the optimal situation would have been, which is to stay in the current stay home, work safe longer. And that there could be, and likely will be, real impacts in terms of the loss of life in this community and further disruption in terms of the higher probability that we'll have to do this again, throwing off school calendars later in the fall potentially. And so I appreciate you sharing this information with us. I think it makes clear what some of these decisions that have now been made for us will translate into in terms of loss of life of our neighbors. I want to underscore and ask you to elaborate on the last point that we can, within the situation we're now operating in, minimize the risk for our neighbors and for ourselves and for our hospital system. And so would you just speak to what some of those precautions might be, and in particular address the use of masks as a way of helping block that transmission?
Yeah. So, I mean, roughly speaking, there are two categories of things we can do. We can simply reduce the number of contacts we have with people. That's sort of the only guaranteed way of preventing, you from infecting other people and other people from infecting you. So you don't go out in public if you don't have to. You work at home if you can. And that if you're not coming in contact with people, there's no way to spread disease. So that's the guaranteed approach. But we know that's very difficult for some people. And but we want to do that where possible. And we particularly want to do that for people who are vulnerable, who are high risk, where it really is, it's life or death for them not to become infected possibly. So that's the first part. But then the other kind of category of interventions are, if you must come in contact with people, do things to reduce the probability that you can become infected or infect others during those interactions. And those are things that CDC has a long list on their website of kinds of precautions people can take, but that includes wearing cloth face coverings. That includes keeping a physical distance between people when you're relatively close to each other. Washing hands. Very, very importantly, if you have just like the inkling of a symptom, right? If you think there's a small chance that you are not healthy, please don't go out and have contact with people, right? Or even if there's a family member or someone in your household who you believe might be infected, it's prudent to keep your distance. And one of the reasons is, as we've come to understand about this virus can spread silently. And in particular, we know that people are infectious in the day symptoms and know that they are sick. And so if you have somebody in your household who has symptoms of the virus, they might have already spread it to you. You might already be infectious without knowing it, without feeling sick.
Thanks for reemphasizing that. My concern isn't just about the steps that have been taken, but also what that signals to the public about the extent of the risk we still have. I know, when the news went off in my house this morning and talked about malls reopening, I could see my teenager's eyes light up about the prospect. And, we had to have the conversation that I hope will be happening across the state, that just because these are options, for those of us who have the ability to stay home, we still should be, to reduce those social interactions as a way of helping out our community and keeping ourselves safe. And so, I am really aware of the need to support those small businesses and others that are really suffering financially. And I hope those of us who have the ability, again, to stay home, will find other ways to do that if we're financially able to do so. So thanks for underscoring the ways in which we can all take responsibility for the choices that we do have, understanding that many of our residents, many of our neighbors don't have that ability. So thank you again for this information.
Sorry, Councilmember Renteria.
Yes, I'm very. What I heard was that, and to Dr. Myers or whoever's still on the phone, that once you've been exposed, it takes up to 2 weeks to show symptoms most of the time, or that if you were to be exposed how long would it take before you start showing symptoms of having it?
So the average, what we call incubation period between becoming infected and developing symptoms is somewhere around 5 or 6 or 7 days. So if you become exposed, if you become infected, you will likely develop symptoms within a week. However, we also believe that maybe somewhere around half of infections never develop symptoms. So for every time a person becomes infected, there's maybe a 50% chance they'll never develop symptoms. But if they are going to develop symptoms, it'll probably happen within a week.
And so the ones that don't develop symptoms, they can spread it to other people. Is that correct?
That is something we actually really don't know at this point. We do know that people who do develop symptoms can spread before they have symptoms, but we do not yet have data that allows us to estimate how contagious, how infectious those people are who are infected but never develop symptoms.
Okay, thank you.
Okay. I think Dr. Escott needed to leave. He's gone over to the commissioner's court, but he wanted you to know why it was he needed to leave. Any other questions for Dr. Myers or for the dean before we let them go? And then we can talk among ourselves here publicly for a little bit. And then if we want to, then we go to executive session. Councilmember Kitchen.
My question relates to the triggers, and there was discussion about about the triggers for being hospitalization, and the trigger was at 100, I believe, was the conversation. So, pardon? I think that's 100 new hospitals was the safety threshold. So my question relates to whether or not there are different triggers or an additional level of triggers that relate to the vulnerable populations. So for example, if we're looking at protecting at nursing facilities or other vulnerable populations, are there different triggers that we need to be looking at or another level of triggers, or is it that 100 safety threshold, is that the only trigger we're looking at?
Well, maybe I can start and Lauren can talk about it. It's actually closer to 1,000 hospital beds filled would be the trigger on one of the hospitalization curves. Yeah. And then your question is different. It's for subpopulations. What will we see as a trigger to change behaviors? So I would say we exceed that trigger today in the nursing homes. We're in terrible shape in our nursing homes right now. And so we do need to develop better policies and practices to protect the nursing homes today. So yes, I think that should be a priority. That's one of the things that we would love to see addressed before their risks increase even further. The same is probably true in the homeless population. We need to figure out how to do monitoring and careful management of that population as well.
And you're muted.
So yes, that was my question. If we drill down to subpopulations, well, we know we already have a problem with vulnerable populations. You mentioned nursing facilities and homeless populations, and Councilmember Cassar is raising questions about workers with, with underlying conditions, and we also have concerns about being out of proportion and the disparities with people of color. So my question then is, as you said, are we working towards triggers for subpopulations, or is that just something that we're aware of we need to have?
Yeah, I think what we're working towards is having adequate data and understanding of where people are affected and being able to have targeted policies and practices to address those areas. And frankly, our knowledge isn't as deep as it needs to be for these areas to give you all an opportunity to then address it. And in some cases, we know there's a problem, and the issue has been more about getting the resources in place to actually make a difference. But from next step clearly is for you all to have better data on these questions.
Okay. Anyone else questions? Dr. Myers, Dean, thank you so much for you are among the people in our community that I don't know when you guys are sleeping. But thank you for being here today, but thank you for everything that you have done the last 6 weeks. And unfortunately, you guys don't get off this treadmill. I mean, you're going to be here for a long time, and you're among the unsung, unnoticed heroes in our community. So thank you for everything that you guys are doing. Please help keep us safe.
Yep. All right. Thank you all. All right. Bye.
Colleagues,